Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Kemi Obajimi. Today's episode features expert perspectives on novel and emerging cereblon E3 ligase modulators, abbreviated as CELMoDs, for patients with non-Hodgkin lymphoma. This episode is part of a larger educational program titled Next Generation Non-Hodgkin Lymphoma Care Spotlight on Therapeutic Approaches Targeting Protein Degradation Pathways. This podcast features Dr. Julio Chavez, Associate Member and Director for Hematologic Malignancies at the Moffitt Cancer Center and Research Institute, and Associate Professor at the University of South Florida in Tampa, Florida. And Dr. Alan Skarbnik, Director of the Lymphoma and CLL Program and Immune Effector Cell Therapeutics Program at the Novant Health Cancer Institute in Charlotte, North Carolina. They will be discussing their real-world experiences and providing expert perspectives on the rationale for targeting CELMoDs in NHL, mechanism of action of CELMoDs, key studies and available efficacy and safety data with investigational CELMoDs in NHL, highlights of ongoing clinical trials of CELMoDs in NHL, and strategies to boost NHL clinical trial diversity amongst underserved communities. For more information on Dr. Chavez and Dr. Skarbnik, along with a link to the complete program, including the associated downloadable resource card, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Welcome to this podcast about the next generation non-Hodgkin lymphoma care, a spotlight on therapeutic approaches targeting the protein degradation pathways. My name is Julio Chavez. I'm an associate member at the Department of Malignant Hematology at Moffitt Cancer Center in Tampa, Florida.
And I'm Alan Skarbnik. I'm the Director of the Lymphoma and CLL Program at the Novant Health Cancer Institute in North Carolina.
This is a program by Clinical Care Options and supported by a grant by Bristol Myers Squibb. We're going to talk about novel targeting therapies for non-Hodgkin lymphoma, in this case, targeted cereblon. Cereblon is a protein involved in degradation of proteins in the cell, regular expression, activities of other crucial proteins involving cell proliferation, metabolism, transcription factors. Cereblon is a molecular target for IMiDs or immunomodulatory drugs, and CELMoDs. CELMoDs are cereblon E ligase modulators, modeled after thalidomide analogs, as we know. Those are very old drugs that had anti-cancer activity in myeloma and lymphoproliferative disease, and share many similarities with IMiD. They have chemical structures that are specifically designed to promote binding of cereblon and therefore inducing targeted protein degradation and transcription factors. Some of the novel CELMoDs include abadomide, golcadomide, iberdomide, and mezigdomide. What is the mechanism of action of CELMoDs, Alan?
It's a little complicated, but this is a cool mechanism of action. So ubiquitins are these proteins that are ubiquitously found in most cells. That's where the name comes from, that are responsible for tagging proteins for degradation via the proteasome. So proteins that should not be there anymore are tagged by ubiquitin, and then that goes to the proteasome, and they're degraded and don't exist anymore. So there are many steps in this process. First, the ubiquitins need to be activated and need to be conjugated and need to bind to the protein via ubiquitin ligases. And then once all that's done, and there's a polyubiquitination, so many ubiquitins are tagged to that protein, then they go into the proteasome to be degraded. Cereblon itself, it's a ubiquitin ligase. Right, so it's part of the cereblon E3 ubiquitin ligase complex. So modulating this protein increases this polyubiquitination, particular proteins. In this case, two lymphomogenic proteins. They're called Icarus and Aiolos. These are key regulators of lymphoid development and differentiation. And when overexpressed and overpresent, you lead to the development of lymphoma and ongoing proliferation and survival of lymphoma cells. So degrading these proteins may lead to lymphoma cell death or less proliferation. So that's why it's interesting to modulate the cereblon E3 ligase complex. This is where the CELMoD name comes from, cereblon E3 ligase complex modulator, as I pointed out before, and trying to decrease the impact of those lymphoma cells in our patients. So this is a little bit different than IMiDs. There are some differences between IMiDs and CELMoDs and how they bind to this particular proteins. IMiDs, they work in an inactive cereblon conformation, so they really are not bound to this specific proteins, Ikaros and Aiolos, even though they work in lymphoproliferative disorders, particularly lenalidomide in lymphomas. They're not as specific as CELMoDs can be. So modern CELMoDs that are in development, such as golcadomide, for instance, have a much higher affinity, or they bind to the active portion of the cereblon when it's closed and it's already bound to Ikaros and Aiolos. So it's a little more specific in promoting the degradation of those proteins because the cereblon is already active at that point and is bound to Ikaros and Aiolos.
Thank you, Alan, to go over the mechanism of action. I know it's complicated, but they look very promising how they work, especially the degree of inhibition of cerebron. Do you think these molecules can be practice-changing NHL?
Well, that's a very interesting question. Unfortunately, we are not 100% in terms of efficacy in our therapies for non-Hodgkin lymphomas in general. Unfortunately, there's a number of patients with aggressive lymphomas that we cannot cure, even in the frontline setting. But after disease recurs, we have very good therapies right now, including CAR T cell therapy, bispecifics, immunotherapy, made great strides, particularly in aggressive lymphomas. But there's still a portion of patients that don't have long-term remission, even with those treatments. So looking into novel agents with novel mechanisms of action is very interesting. So you can kind of circumvent the resistant mechanisms that are in place after these therapies have failed. So that's one of the places where it's really interesting to look into CELMoDs in particular, but also trying to bring them to the front line. If we can control disease long-term or even cure, particularly in aggressive lymphomas, more patients in the front line with newer combinations. And R-CHOP works great, but we have about 40% of patients whose disease is going to relapse or does not respond to that therapy if you take all subtypes of DLBCL together. So adding to R-CHOP or to that backbone with something that's not chemotherapy, something that's oral, it's very exciting. Having something that may end up being adopted, unintended, ubiquitously everywhere, where access to the drug may not be such an issue as it is with CAR T cell therapy, for instance, may make a lot of difference in how we treat these patients.
I agree. Having alternatives is important. What is particularly exciting about this is the mechanism of action, the degree of inhibition of cerebron, and as you mentioned, the possibility to be very specific and also perhaps less toxicity. So I'm going to talk about the key studies, available efficacy data with investigational CELMoDs in NHL, phase 1 first-in-human trial of golcadomide in relapsed refractory NHL. We used to call the trial the CC99282 NHL001. Now it's golcadomide. The trial has two parts, a dose escalation phase and a multi-cohort expansion phase. Since it was first in human, so we started with the monotherapy and different schedules, including the lowest dose was 0.2 milligrams on a 5 days on, 7 day on a 7-day schedule. However, there were other schedules studied, like the 7 days on, 14 days schedule, and the 14 days on a 28-day cycle. So patients were included if they have at least 2 lines of therapy, or patients who had 1 line of therapy but didn't have any other viable alternative. We're currently enrolling in the Part B portion of the study that includes combination with rituximab, tafasitamab, obinutuzumab, and valemetostat. And the primary endpoint was safety, but also recommended phase 2 dosing and efficacy. Give you a little more historical perspective of this study. We have the avadamide, which was the first CELMoD, a less potent inhibition, however, had activity. In combination with rituximab, the overall response rate was about 23%. The trial also included a combination with the mTOR inhibitor onatesertib and also the BTK inhibitor esperbrutinib, and the response rate increases slightly, almost 30%, with mTOR inhibition, with a BTK inhibitor inhibition, almost 26%. However, it had activity in a highly refractory disease, obviously. However, in the gold calamine, the 0.2 milligrams, overall response rate was 33%, CR rate 13%, but that increased dramatically when the dose was higher at 0.0 milligrams, 55% overall response rate, 27% CR rates. For CELMoDs, the most common toxicity is hematologic toxicity. In this case, with abadomide, neutropenia, grade 3 was seen in 36% of patients. With golcadomide, it was about 50% of patients. And from my experience, several patients actually required to be on growth factor support to keep counts stable. There were other side effects such as anemia, thrombocytopenia, but key toxicity was neutropenia. Other non-toxicities included constipation and diarrheas, a little bit lower than with abadomide and even than with lenalidomide. Infections also were reported. About 45% patients had any infections, with 18% grade 3 and 4. To summarize, in clinical trials, the common side effects associated with CELMoDs include neutropenia, anemia, thrombocytopenia, constipation, or diarrhea. There have been infections reported, and also other toxicities such as hypokalemia, hyperglycemia. And they may not all related to CELMoDs, mainly from trial experience. Hematologic toxicity was the most common. Alan, maybe if we can expand a little more, what do you believe CELMoDs fit in the future treatment of NHL?
Looking at the data just presented, the first thing that comes to mind is the safety of the drug. Having cytopenias as the main side effect, and cytopenias being something as hematologists and oncologists would deal on a very common basis. And there are ways to circumvent that with growth factors or differential schedules like the 2 weeks on, 2 weeks off here, or even transfusion is needed. But the other side effects are not as prevalent or prominent. It doesn't seem to have a lot of rash or any neuropathy at all here. And I don't think any thromboembolic events were seen in the clinical trial. It's a reasonable treatment to be combined with other therapies that we have available right now, given the safety profile. The preliminary efficacy is interesting. About half of the patients responding at a higher dose with rituximab, although not all of them were complete responses, but still, in a heavily pretreated population, is certainly an interesting number. And finally, this being an oral agent, it's something that is more easy to access across the board outside of treatment centers that do immunotherapy, for instance, where patients need to travel to that site to receive that therapy. So this is something that certainly, if approved, can be largely used in the community with ease. As I mentioned before, where I see this fitting is as a treatment option for patients who have gone through immunotherapy and the treatment has failed. So something they can take close to home without needing to travel far for it. Interesting efficacy there. We need to have certainly more data in that particular patient population to determine that. Furthermore, combining with treatments that we currently have available, given the safety profile, is an interesting approach. And obviously, clinical trials will tell us how that works out. There are long ways to go. So those are the places where I see this fitting at this point.
I agree with you. There is a space for NHL treatment regimens development, and CELMoDs may fit in those areas where the unmet need is there.
So we're going to talk about some of the clinical trials that are ongoing and some about to start using CELMoDs in B-cell lymphomas. It goes along the lines of what we were discussing before, where this may fit. So the first trial I'd like to talk about is the trial called GOAL-Seek-1, which is an interesting trial. It's a phase 3 trial that's open. It's an international trial, has 850 patients targeted. It's a randomized study for frontline therapy of high-risk large B-cell lymphoma. So it's going to be golcadomide, the CELMoD plus R-CHOP versus placebo plus R-CHOP. So it's a double-blind study with the primary endpoint of progression-free survival. So that's interesting. R-CHOP is the standard of care for large B-cell lymphoma in the frontline setting. It's one of the standard of care. We have Polar CHP as well, for instance, right now. Nevertheless, that's been what we've been using for many, many years. with efficacy in the majority of patients, but unfortunately we have 35 to 40% of patients whose disease either doesn't respond to treatment or comes back. So adding something to our CHOP is certainly reasonable. And as I discussed before, the safety profile of this drug can allow that to be done. The primary endpoint is progression-free survival, which also reasonable in aggressive lymphoma, that you will need to treat if the patient presents progression or residual disease at the end of treatment. So that's one of the clinical trials right now with CELMoDs in B-cell lymphoma. Very excited for this trial. Another trial is called CARMOD. It's a phase 2. It's about to open as well. It's going to be in France, if I'm not mistaken. It's a smaller trial. It's a 65-patient trial, but the question is very interesting. This is using golcadomide shortly after CAR T cells. So patients who are receiving CAR T cell for relapsed large B-cell lymphoma, they're using golcadomide sort of like a consolidation or adjuvant to this treatment approach. It's not for patients who got CAR T, then the disease relapse afterwards. Is together with the CAR T and trying to improve on the outcomes of CAR T. The endpoint is the complete metabolic response rate, MR rate. And my understanding is that will be compared to historical controls, given the plethora of data that we have with CAR T cell in the setting for this patient. So for a treatment that is not efficacious for everyone, certainly there's a level of failure of CAR T. Adding to it is also very, very reasonable with the drug that, while may increase the cytopenias that we see with CAR T, but again, we know fairly well how to manage cytopenias at this point. Certainly we need to be careful because it's post-CAR T. It'd be interesting looking at how much more cytopenias we're seeing with the additional golcadomide. I imagine it will increase, but it's reasonable to add to that. And there are a couple of trials that are already recruiting. Both are phase 1. One is looking into iberdomide plus R-CHOP or polar-CHP, and golcadomide plus R-CHOP or polar-CHP. It's a phase 1 in patients with untreated aggressive B-cell lymphoma. And there's another trial that's recruiting. It's a small trial, phase 1, using golcadomide plus rituximab after CAR T cell therapy for patients with B-cell lymphoma, for patients who had relapsed disease in that study. Those are phase 1 trials that are looking at maximum tolerated dose and adverse events in this patient population. As I said, they're still ongoing, so we should have more data coming up soon. Very exciting times, very exciting to have a novel type of treatment being studied in B-cell lymphomas overall.
It's a exciting compound. I like the study of CARMOD. Started the golcadomide 5 days after CAR T, and it's not supposed to affect CAR T cells. So there is a rationale to actually combine early in the post-CAR T setup. They did a study with lenalidomide going along the same design, and there was some activity. It's a very promising frontline setting in the combination with immunotherapy. So we're moving along very well. We're going to shift gears a little bit and talk about how can we boost clinical trial enrollment in non-Hodgkin lymphoma among underserved communities in order to improve trial diversity. One option is to have an agent that can be done closer to these communities. Some of barriers are clinician barriers. One of the having an understanding of the patient background in terms of language barrier or literacy is important. But also some of the logistic barriers. Some patients live far away or don't have enough transportation, or they're low-income communities, and they don't have insurance that will cover for treatment in some cancer centers. We see that a lot. Some of the trial barriers, in my opinion, was the informed consent that is not in the language that is preferred by the patient, having a language translated into their language is also the steps. It has to be approved by the IRB and also by the sponsor of the trial. Some of the institutional barriers, Alan, I'd like to hear your opinion.
This is something that overall the FDA is very interested in improving diversity in clinical trials. Unfortunately, most clinical trials are not necessarily reflective of the real world population that we see from a racial and socioeconomic standing point. So increasing participation of underserved communities in clinical trials is very, very important, where We will be able to help those populations more. We'll understand better how the treatments work there, and also give the opportunity for these underserved communities to benefit from the clinical trials directly with participation. Other things that are of interest is in promoting access to these clinical trials. If the clinical trials are present in sites where these communities are, you will certainly improve access if they don't have to travel far to be able to enroll in the clinical trials. And more, the sponsors are understanding that extending clinical trials beyond the traditional academic center settings is important to capture a more representative population, representative of a reality. So, participation of community settings is important here. Investing in that is very important. Having this mix of academic and community and collaboration between academic and community is very important. In particular, for clinical trials, they're looking for an oral agent or something that can be delivered close to home and doesn't require an apparatus to deliver CAR T cell, for instance, which is certainly more logistically complicated. Other things are the time commitment that we demand of patients in clinical trials. In a phase 1 trial, having to stay long days in a row, several times a week to collect labs and etc. may be a deterrent for patients to participate. They need to arrange transportation, family, childcare sometimes, take time from work, etc. So minimizing those social impacts in patients is very important to improve access and diversity in the clinical trials. And finally, there needs to be an investment of extending clinical trials beyond the United States so we can promote this where communities are from, Latin America, for instance, where resources are quite scarce. We can increase clinical trial access in those countries and really get these treatments to the populations where they are. Outside of Europe as well, Africa, Southeast Asia, for instance, are certainly places that will benefit from more clinical trials being present there.
Yeah, I agree. That will bring opportunity to treat patients of different backgrounds. Those are good ideas. And in terms of what steps we are undertaking in our practice, for instance, working with medical societies like a Leukemia Lymphoma Society or our local oncology societies, like, for instance, the Association of Oncologists or FLASCO, they actually undertake programs for education and also patient-related programs where they provide education in their language. Also meeting with community leaders that will be the contact person for the underserved communities. So that's one of the undertakings. We talk about the CELMoDs, mechanism of action, some of the early clinical efficacy and safety data, but also how can we integrate these therapies in clinical trials, especially on patients who are of diverse background and that usually are not enrolled in clinical trials. But any other final thoughts, Alan?
It's a very exciting time to clinical research in lymphoma. There's a number of different treatment modalities that are available and coming up as well in studies. So this is great. Improving diversity is very important. So we understand how these treatments work in a population more reflective of the real world of the patient that we see on a day-to-day basis. I'm very excited to see where CELMoDs in particular are going in lymphomas. Hopefully they will go a long way and improve outcomes for our patients so they can live long and better lives.
So with that, we conclude the podcast. Thank you very much.
Thank you very much, Dr. Chavez and Dr. Skarbnik. And thanks to you, the listeners, for joining us. As a reminder, to view the full program on next generation non-Hodgkin lymphoma care, spotlight on therapeutic approaches targeting protein degradation pathways on the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.